position to rest.
Yeah, so CPR you guys going to do, you will see the feedback device, so make sure, right, as a team leader, you want to make sure that the depth and rate is adequate. The top bar shows you how deep they go, and the scaler over there on the right side shows you how many per minute, so you want to make sure it's centered.
Okay.
So you guys can use your protocols, you can talk to each other, right? Any drugs you want to give it via the arm. Any electrical therapy, you will actually press the buttons to do it.
Okay.
There's pads there, you can put the pads on, but everything is connected to this box. What else you could intubate. And any math you need to do, like a drip, do it on a piece of paper, right? And then you could start the drip on the arm there. If you're let's say, out of the, not sure what to do or out of the ideas, you can talk to each other, right? However, if let's say someone gives you an advice to do a certain drug, a certain procedure, and you say, okay, we'll go with that, and that was the wrong advice, that's on you still, right? But you can talk to each other. And if you see someone who's making a mistake, and you know it's a mistake, right? Say something. Don't just stay there idly doing nothing.
That.
All right, you guys ready to go?
Yeah.
All right, you guys get a call. You guys ALS. You're gonna respond together. You're responding to an 86-year-old male with chest pain, radiating to both arms. You're going to a home residence.
Is my scene safe?
You're seeing safe.
Okay, everyone has proper PPE, we're wearing gloves, masks.
Yep.
Yeah. How many patients do I have?
Yeah, one patient.
One patient. I don't see the need for C-spine right now. Because it's medical call and the mechanism of injury, chief complaint, nature of illness is chest pain.
We're gonna say no trouble.
No trauma? Okay, what do I see when I get there?
Okay, we're gonna say the family members let you inside the house. There is a 86-year-old male. He is in his couch. He's laying semi-fowlers. He looks like he's in somewhat of respiratory distress. He's breathing fast and he looks diaphoretic.
That's my general impression. Diaphoretic 86-year-old male, not looking great. Airway intact. Can you talk? Can I say hello?
So go ahead. Go ahead.
Hello, sir. What's going on?
Oh, I'm having terrible pain in my chest.
Terrible pain in your chest. Airway intact. He's talking to me. He's alert.
How do you know he's alert?
He's talking.
Well, he could be talking, but does that mean he's fully alert and oriented?
No, it's not oriented yet. Do you know where we are right now?
Yes. Does that answer your question?
No.
So how would you ask that?
Where are we right now?
My house.
My house? Okay.
Residence, yeah.
Resident? What were you doing before this?
I was actually moving some stuff in the house, and I started having this pain in my chest.
Can you tell me your name, sir?
My name is Mike.
Mike? Okay. Do you want Monday is Mike?
He says June.
Junior, okay, my patient's alert, oriented, 23, unsure about time.
Okay.
Airway intact, he's talking, breathing, I want rate, depth, and quality.
Okay, so we're gonna say he's breathing rate of 24, he's breathing good tidal volume, and there's some accessory muscle use. So you see some labored breathing.
How are his breath sounds?
Where's the stethoscope?
Or I guess I'll get one of my partners.
You could do it, or you could, it's up to you. You could do whatever you want.
Your airway.
Alright, and tell me where you're auscultating exactly?
On
On the patient.
rotating
On the front? Okay.
and the back.
And the back. Okay. We're going to say lung sounds are clear. However, you do see he's tachypnic and he's breathing, and you see accessory muscle use.
Okay, we're just going to throw on a nasal cannula off it, put him at 4 liters.
Okay.
Show him, please. What's good with you guys?
Yeah, I mean, get a.
Oh, can you get a pulse ox?
Okay. Room air pulse ox 89.
We'll put a non breather on it. We'll put it at 12 liters.
Okay. You have your partner here?
Can you put on the non breather? How's his skin? You said diaphoretic,
Yeah,
general assessment.
His extremities are cool, and he is diaphoretic.
Okay, pulse. I feel for bilateral radial pulses.
Radial pulses are present, they're regular.
Equal?
Equal.
Okay, any obvious bleeding or external hemorrhaging?
You do not see anything obvious.
Okay, critical patient will continue to my secondary assessment now. I'm gonna have one of my partners get a blood pressure, a heart rate, respiratory rate in 3 lead in 12 lead.
Okay. While they're doing the EKG, the blood pressure comes back at 94/68. Heart rate is going to be 58. your respiratory rate is 24. With oxygen now, is saturation improved to 96%. No, everything is already connected here. If, when you guys are going to do CPR, put the pads on the monitor.
Okay, I'm gonna ask the patient about past medical history.
Okay, the guy says, I have a coronary artery bypass graft, cabbage.
Mm-hmm.
I have, in 2003, I have hypertension. I have coronary artery disease, and I have elevated cholesterol.
Any allergies?
No allergies.
What medications are there?
I take metoprolol,
Mm-hmm.
I take Coumadin, and I take simvastatin.
Okay, when did the pain start?
Started about 1 hour ago.
What were you doing when the pain started?
I was moving some stuff around the house.
Moving. When you stopped moving stuff, did it help?
No, actually, the pain was still there.
Pain was still there.
Yeah.
Does the pain move anywhere?
Both of my arms.
Both of your arms? Okay. 1 out of 10, how bad is it? 10 being the worst pain of your life?
It's 9.
9? Okay, then we're gonna get a 12 lead. On to the
Here's the one in the top.
top right.
One idea.
Yeah, can you get we'll start with an 18 gauge in AC. Looks like a bump.
Wait, what? Oh, the elevation between AVF and hospital.
We're gonna go inferior wall MI with a possible lumbar branch.
Okay.
Right on the branch, please. Yeah, right on the branch. Oh, well, yeah, we'll do right side of the
Okay.
EKG.
We're going to say for this one, you do not have V4R involvement. So no V4R.
Just sinus rhythm, okay. I'm gonna ask him, are you allergic to aspirin?
He says no.
We're gonna administer 324 milligrams of aspirin. And the current count is 94 over 16. No, we're not. Yeah, we're not. Give aspirin. Inferior wall. Oh, yeah. Transmit the STEMI to telemetry for one.
Okay, they say, okay, they received it. They say,
Is
you're
that,
authorized
is
to
that
listen
his
to
new rhythm?
Yeah, the guy says
Oh,
he's
hang
not
on,
feeling
hold
so
on.
good.
Do you have a pulse?
He does have a pulse.
Okay, we're gonna new blood pressure.
Your blood pressure comes back at 89 over 52.
Meditating. Oh, mental status.
He's responding to name only.
Name. Okay, we're gonna cardiovert. Yeah, gonna ask for that, but we'll cardiovert. No, that's the one on the monitor. Yeah. Cardiovert starting at 100 joules, please. Pads are on.
No, the pads
Oh.
are not on.
96 is set to 100.
Okay.
Wait until the pads are on.
Yeah.
Alright, so we're starting at how many joules?
100 charge. Do you want charge? Everyone's clear?
Okay, it's clear.
What?
Yeah. Shocked? Okay. Does that
Nine
change your
27.
something? Is the rhythm still VTAC?
Same rhythm as
Same.
mine.
Patient still has pulse?
He still has a pulse.
Okay, start at 200 joules then. Meditating status still the same. Response
He's
the
not
same?
really responding anymore.
Unresponsive. Shock, everyone clear?
Shot.
Second shock. Patient still has pulse?
You cannot feel a palpable pulse.
Okay, we're gonna now start CPR, defibrillate first, try just setting it to 360 or max 200. Start, okay. While he's doing that, can someone start CPR?
Nine down, 928.
928. Okay, clear? First shock, 920. Keep doing CPR.
Be alive. Hour.
Okay, we have an 18 gauge. I'm gonna have you just pre-charge the monitor.
Right, so my advice to pre-charge it 30 seconds out.
30 seconds
right?
out, not
Some manufacturers will dump the charge if it's too long.
Okay. We'll continue CPR, making it's good CPR right now. We can give lidocaine. Oh, can you start bagging him? We'll put in OPA, use BPM, 15 liters, intubate after 2 cycles of CPR. Continue with meds after the second shot.
We'll be lighting start with an FE first.
Yeah, we'll start first epi
That's
at
okay with you. Let me know when you're ready.
first epi at 9:29.
Ready.
Okay, we're giving 1 milligram epi, 1 to 10,000 at 9:29. Let me know when you push it. We have 1 more minute till we can shot again. Let me know when you push the epi. First epi's in at 9:29. Okay, can you check for pulse?
No pulse.
No pulse. Okay, everyone clear.
Switch.
Shot.
Shot.
Okay. Second shot is at 9:30. Continue CPR. Yeah, you're good to 2. How's he? What's the O2 saturation?
Are you going to get to saturation someone cardiac
Oh
arrest?
no.
Do we pre-oxygenate someone cardiac
No.
arrest?
No.
Okay, go for the 2. And then do you want to push 100 milligrams of lidocaine or 300 of amio, whatever. Amios are out. Just push 300.
Epigastric.
What's capnography on YouTube?
Part of Helios.
Yeah.
System. Right, you guys are standing there, you see you struggling. Right? Alright, take the back, squeeze the back, let him muscle too. Alright, we're gonna say negative epigastric sound. Positive. Positive. What do you expect the entitled CO2 to read?
Well,
Not that
I
Maybe
guess
like 25, 30.
Probably not 25, 30, maybe like 18 if he's doing excellent quality CPR. Maybe 16 to 18. Right? You're not gonna see 35, 45 obviously.
Alright, 9:32. Okay. You got it.
You want to
Okay,
stay on
pre-charge.
medication?
Pre-charge the monitor. Oh, there's conditions here with the Lucas.
No, there's no Lucas.
Oh, you want to check
There's no
for
conditions.
pulse?
Yeah, check for a pulse.
Check for pulse.
Pulse. Do you have a pulse?
Pulse is present.
Okay, I'm gonna have you cancel the shot.
So,
There's the sun button is always at the bottom right here.
Okay, we're gonna continue bagging and we're gonna get a whole new set of vitals.
Okay? What specific vitals would you like to know?
Blood pressure, heart rate, respiratory rate, capnography.
Okay, blood pressure comes back at 70 over 52. Saturation reads 96%. His respiratory rate is whatever the rate he's bagging his patient at. Your entitled CO2 reads now 76.
you want the next set of 12 lead?
Yeah. We'll take another 12.
12 is the same, it's unchanged.
What's heart rate?
What's the heart rate?
120.
Check for response.
How responsive is he now post arrest?
How would you check that?
Squeeze.
Squeeze your hands, check the people.
See if he can respond.
He does not follow commands. Does not follow.
follow commands? Okay. Okay, I know. I'm gonna fix blood pressure. 70 over 52.
Bullets?
Yeah, we'll start with the 250 bolus of fluids.
Okay.
Does that do anything of normal cylinder?
Let me know when it's given.
Is that the second?
Yeah, it's, the totally doesn't change in terms of your ST segment deviation.
No. Okay, now we'll recall telemetry
Yeah.
and transmit the semi.
Yeah, they authorize you to take them to the cath lab.
Okay. We have somebody approved at 9:30. Okay, and we're starting with 250 drip of normal saline at 9:34.
Or
Does he have a pulse still?
he does have a pulse.
And is that his new rhythm?
His knee rhythm.
Can we get a repeat set of blood pressure and heart rate?
The blood pressure is 82 over 54. Heart rate is 72. Saturation is 96%. He's being backed by BDM. And his end-tidal CO2 is 45.
Okay.
Press the wire.
To bring up to 90.
I mean, like,
Dopamine or
Norepi.
You're probably Norepi.
So we can discuss and decide what you guys want.
Would you guys go Norepi, dopamine, or would you push stress epi?
right?
No push stress epi though.
No.
If it's an MI.
You don't wanna elevate the heart rate.
Yeah, okay. So Norepi.
Norepi.
Okay.
Yeah.
5 mics a minute.
Okay.
What's the concentration?
Let's see, that's, I think that was 4 milligrams. Put it in the next bag.
Oh yeah, it's 4 milligrams per 4 ml.
Yeah.
So you can choose what concentration you want.
So these are concentration, you guys using 4 milligrams and 250 ml, right? Or which
Yeah.
one? Yeah.
4 milligrams.
Yeah. 4 milligrams per.
250 ml.
Yeah.
Okay. Or we only need 5? Or 5 mics.
Yeah,
We're
the
using 4
max is-
milligrams.
I think the max is 10, right? 10 mics.
Max is 20.
20 mics.
20
Dopamine is
mics.
20 mics.
Microgram.
I know it's
So 4 and 250.
60.
That's a 1600 mics.
Yeah,
You
so
said
that's
5.
1600.
Actually, that's 4 mics. Or I guess
So
it's
just, just to clarify, well, how much you starting with?
We're starting with 4 milligrams
And a
in a
250.
250 bag.
And then how many per minute? How many micrograms per minute? You said
5 mics.
5.
per
Good.
minute.
So the order is 5 micrograms per minute. We're gonna put 4 milligrams into 50 ml. Is this a weight-based drug or not?
No,
No.
it's not.
Very good. So now we gotta find out drops per minute.
So
We'll use one.
it's gonna be
Macro.
5 mics times 60, I believe.
Did you go micro or macro?
You would go on micro.
Micro, okay.
Yeah,
We'll use
so
60
you can
drops.
measure it. So that comes to 5 times 60 is 300 over
The concentration.
4,000 micrograms.
Over, what do we say? Concentration of 1600 mics.
Yeah. Yep. That's it. 300 over 1600.
No, that's not.
It's like, I think it's like 1 drop.
3 over. Patient's still responsive and.
Patient is not responsive.
No, well, he has
Still has a
still
pulse.
pulse. Okay.
It's 300 over 1600, right?
Yeah.
So that's gonna be
3 over 6.
5. It comes like 1 drop every 5 to 6 seconds. But it could be wrong. It'd be like 10 drops a minute. And what do you get?
guys are confusing.
No, that's not it. Okay.
Alright.
It's 5 mics a minute.
Right? So you have 5 mics per minute, that's 4 milligrams and 250, right?
Yeah.
So 4,000 micrograms.
Yeah.
And 250.
Mhm.
60. Yeah, it's
1600s or
Yeah.
concentration?
I think it's 16.
Oh, you think it's
mics.
16?
It's 16 drops.
1600 mics?
Yeah.
1600s are concentration.
I have a vial on my desk. I'm gonna bring you guys so you can study it.
The concentration is 4 milligrams.
Mhm.
50.
Yeah.
So that's 4,000 micrograms.
Oh,
divided by
yeah.
250.
Yeah.
Yeah.
Right?
Yeah.
That's 16.
Yeah.
1600. 1600.
But that's 60 milligrams.
No, that's 16
micrograms.
micrograms.
This
You can-
So 4 milligrams per ml.
He
Yeah.
converted it to micrograms.
So this is. Did you guys? Did
Yeah.
I show you how to do it?
Yeah.
So you take
Snap.
a 4x4, you snap it, right? So this here, 4 milligrams, right in 4 ml. So you're gonna put this whole vial into 50 bags.
You have to do the top part of the equation.
It's 5 micrograms
So
times
5
60 drops
times
per ml
6.
over concentration, which is
Right?
300.
it's 1600.
Yeah,
Over
1600.
concentration.
So that's 300 over 1600, which should give you
Also-
5 point, like
3 over
7.
6.
3, 6, 9, 12, 15.
Yep.
And then
1 every like 5.3. Not even 5.13 seconds.
So what you guys got? Drops per minute.
so that's gonna be
5 minus 5.
10. It's gonna be like 10 drops per minute.
10 drops per minute. So 1 drop every 5
About
seconds.
6
Yeah.
seconds.
I don't think it's 10 drops per minute.
I think it's a drop every.
Oh wait. Isn't it like 5 times 60 over the concentration?
Yeah.
So
Concentration is 1600 milligrams per kilogram. Or not milligrams per kilogram, just 1600 milligrams per ml.
And I was there anyway.
You have to stay in there. Everybody's gonna. Unless someone takes over for you, then you could assist them.
Patient cells most. I think
5 drops a minute?
Incorrect.
No.
Incorrect.
Francis, do you want to try the math?
Call
Back.
it
I'll back.
Have someone bag. Then you
I'll
assist.
back. You do the math.
Over 16.
I would say write it out on a piece of paper so that you guys are not confused. Just to repeat, right? We're doing 5 micrograms a minute.
Yeah.
We're going to put 4 milligrams into 50, which is going to be 4,000 micrograms into 50 ml bag.
Yeah.
And then we're using a 60 GTT, which is a microcent.
Uh-huh.
If you would have asked me a week ago, I would have done it. If you would have asked me this a week ago,
Right? And something to keep in mind, patients like this, who have labile like vitals, meaning like poor vitals, if you don't get the pressure on board, right, in a relatively quick time,
Yeah.
they may rearrest, right? So that's why it's important to get this math down.
Over recycled blood pressure.
It's coming down. Let's say it's now decreasing to 78 over 52.
We got a prep
we got Francis. What the fuck are we doing wrong? 5 is 5 micrograms times 60
It's 300 over 1600.
over. So the concentration has to be wrong?
No, concentration's right.
No. 4,000. That's 13.
No, our concentration rate is 16 Because 4,000, like if you go
I
to
know the 250 multiplied by 4.
yeah, that's, and then
I'll give you guys another minute to
Okay.
figure this out, and then I'll write it on the board.
How far off are we?
You're wrong.
By a lot?
Yeah.
Okay. So,
Switch.
You're switching to drugs?
I'll stick with
No,
I'll stick
that's,
with
that's,
it.
you know, that's not, you know, like I said, if you're in the bind, right, let's say, you know,
Yeah.
you gotta get processed on board, right, and you gotta give to another drug, yeah, I mean, like, it's better than nothing.
no drug, but you
Yeah,
want to get
but
the right
what I'm
recipe.
saying, that's not the optimal level of care, right?
Yeah.
If you decided we want alpha response and decided to go with
One-
Norepi,
1 drop every 3 seconds.
1 drop every 3 seconds.
20 drops.
Okay.
Yeah, 19, yeah, but close.
19.
Yeah.
Alright.
So 19.
Okay.
19.
We can start.
How did you get? How'd you figure this out?
It's a secret.
Right now, 34, right? That's it.
Huh?
I don't have my phone. My phone's right there.
No, but like, how did you? They were all sitting. How did you figure it out?
You needed time away from a piece of pen
Yeah.
and paper.
I
But-
took a micro sleep and then
19. So I'm gonna put this down so you guys can see it, right? Actually, you hold it, so it's on the board.
wait. I think
So
I
next
think I
just
figured
like-
it out.
Thing off the vial.
Yeah, absolutely. Yeah, spike
Oh.
it, bake a back. So I'm gonna write it on the board so you guys can see it. So we said we're giving 5 micrograms, right?
Yeah.
And over 1 minute. And then I use the mesh analysis, so I go top to bottom. So here it's gonna be mics,
I
right?
don't like that.
So we're gonna put, we said we're gonna put 4 milligrams, right?
Yeah.
Which becomes 4,000 in 250 bag.
Mhm.
And then to close this out, I gotta get mLs at the bottom. So this is gonna be our 60 GTT set, right? So then units cancel, and then we're left with drops per minute, right? And then I can cross out my zeros, and then I see what I can reduce. I can reduce 5 into 40, goes 8 times, right? And I got 8 and 6 here, right? So I can go by 2, be 4 and 3, right? Nothing else I can reduce. I got 25 and 3, and I got a 4, right? Nothing else,
Mm-hmm.
right? So 25 times 3 is
75.
yeah, divided by 4. So 1 minus 4 is 3, 5, 8,
Comes out to like
8.75.
3, yeah, 7 minus 28, right? So you can continue 18.7. Let's say you round it to 19 drops, right?
Mhm.
Yeah.
So 19 drops, this is drops per minute.
Uh-huh.
And roughly, let's just say it was 20 drops per minute. It's going to be 1 drop every 3 seconds.
Mm-hmm. Let me know when you start the drip.
Yeah, we're working on
A 4x4?
Not sure where you guys are making a mistake, but yeah, this would be the setup for this. Start gathering your report for the capital beginning, all right?
Are we starting the drip now? Yeah. Has blood pressure and heart rate again?
Alright, we're gonna say current blood pressure is now 110 over 64. Heart rate is now 72. Saturation is 96%. End-tidal CO2 is 40.
Yeah. Or, yeah.
Stop what?
maintenance titrator. Right?
Yeah, I guess we're fine. We're also at the cath lab now.
Alright, so are you ready to give your report?
Yeah.
Alright, go ahead.
I have an 86-year-old male with an inferior wall MI, risk factors of past cabbage, elevated cholesterol, CAD, and hypertension. most recent set of vitals is 110/64, heart rate 72. Respirations are mechanically assisted with a BPM at 15 liters. He's on 96 room air, capnography of 40. Our patient arrested at 9:28. We gave 2 doses of epi, 300 milligrams, 2 doses of epi, 2 milligrams per 10,000 ml, or 10,000 concentration. We gave 300 milligrams of amio at 9:32. We gave 250 milliliters of normal saline at 9:34. 9:38, we started 5 micrograms of norepi. Our patient it takes metropolol, somatostatin, and Coumadin. No known allergies.
Okay. So, how do you feel you guys perform?
Bad math.
Huh?
Bad math.
Bad.
Good until math.
But we saved it. We made the cutoff at the time we gave it.
With the, yeah. So I wouldn't say it was bad. I would say your start right of the cardiac arrest was good. You have team roles, right, and you started doing proper resuscitation. I saw good switches, proper electrical therapy. Where it starts to break apart is right when the math right is started. I would say, as I told you, right, if you decided on the proper drug, the best course of care, right, if you want an alpha-1 response and you said norepi, that's a good drug. He's having an MI, right, into the wall. If you're going to give him epi-push dose, you're going to increase myocardial demand, right? So just because it's easy to implement, it doesn't mean it's good for the patient. So norepi was a good choice, but the math needs work. I wrote it on the board, right?
Now you
Yeah, now I'm like, obviously, like,
Right? But we want to get it. We want to practice on the math. Why? Because the moment the guy comes back from cardiac arrest, it's like your ultimate shock, right? If we keep him in that like peri-arrest state with low blood pressure, they're going to re-arrest. Sometimes you may have like low blood pressure, like 50/40. You're not feeling a pulse, so you have to continue compressions. You're going to go back to where you started. So we give the fluids. With the current protocol changes, it's no longer 250, it's 20 ml per kilogram, right? So we'll guesstimate his weight, do the 20 ml per kilogram, and then we're going to start the pressor. norepi is the correct choice. The other thing, what I can give you a little tips on, as a team leader, you want to, after a few minutes, you want to summarize the case. So you will say, hey guys, we're doing this cardiac arrest for 10 minutes. We gave 2 shots. We gave 1 dose of epi, right? And we intubated, right? What else can we be doing, right? So somebody will say, okay, the next, it's a shockable rhythm, so we can consider giving antiarrhythmic medication. Somebody may say, okay, what about H's and T's, right? What do you think is the cause, right, of this possible cardiac arrest? What do you guys think? MI, right? Yes, thrombus, right?
Yeah.
H's and T's, so T is a thrombus. So you guys, so if, as a team leader, you summarize, perhaps maybe you may not see what's the next action, but somebody else may be, oh, like, we haven't done this, or that's what we need to do, or we need to get history or something else, right? And the other thing, right, when you're giving doses to the drugs, you want to use closed loop, so you'll say 1 milligram epi, you want to repeat back, okay, I'm giving 1 milligram epi, IV push. Or I'm giving amiodarone 200 milligrams, IV push. So you want to repeat back, so there's no confusion, there's no ambiguity, right? In terms of your summary, your report, you started out good, but then you went into that report
like
with the
about
vitals
the
and like ACLs. So I gave a little presentation. I don't know if you were present there. I'll tell you how to explain better on it. But you don't have to explain like we gave amio and epi, right? Just say we followed our protocol with AHA guidelines. If they ask you specific drugs, you can do it. But the way you want to start is this: we're bringing you so you'll say, we'll bring you a STEMI, and we got an 86-year-old male patient who presents with past history of cabbage, 2003 hypertension, CAD, and high cholesterol. This sets high risk factors, right? Which you did, right? Presents with chief complaint of chest pain with radiating both arms, which began 1 hour ago, right? So you tell them the chief complaint. And then you want to evaluate on the chief complaint. So you'll say, upon our assessment, right, the patient stated that pain, right, the location was in the chest and radiated to both arms. He said it feels like pressure. He says that 9 on 0 to 10, right? And it's been lasting for an hour. It was gradual and onset. He was doing housework when the pain came on, right? And then you will say, you want to say why the patient called 911, right? What changed today? So we didn't really assess that. And then since this episode of chest pain, is it getting worse? Is it improving? Is it unchanged? So you want to track that. And then after we do all that, we're going to state the patient's allergies, the medications he's sparingly on, and any physical exam findings like fetal edema, jugular venous distension, right? Any implantable pacemaker defibrillators. You know, and then you can give your vitals and the treatment. So vitals are this, and this, and this is the treatments where the patient went into cardiac arrest at this time, went per the REMAC ACLS guidelines, right? REMAC protocols ACLS guidelines, but got ROSCA this time, and you had standing on the ROSCA right here. So the way your presentation runs is initial is like the one-liner, right? We have age, sex, pertinent history, with a chief complaint, duration of this time. Then you evaluate on the chief complaint. So basically, any findings on OPQRST, and you give those findings. The reason EMS was called today, what changed is that this is the patient has never felt before, but this is the exact same time he had a heart attack in the past, right? And since this chest pain began 1 hour ago, there's no improvement, or it improved with 3 nitroglycerins and rest, or it's unchanged, right, with medication, whatever the case may be. And then you state, right, allergies, what the medicines they're on, your pertinent physical exam findings, right? Right. So that's how I would give the report. I gave this handout in the class and actually recorded the video. I'll do it again, but you can.
Oh, yeah. No. Yeah,
Oh,
that was
yeah.
probably Sunday.
You guys have any questions?
May I have to take a picture?
Yeah. Or I'll just take a picture.
Yes, I'm.
Any questions about this case? No?